All right, this is the last of the hepatitis virus videos that I'm going to make. This is the HCV virus video, so hepatitis C. Once again, go back and review your pathophys notes for the prodrome, preicteric, and icteric phases, and you can check out the other videos for HAV, HEV, HBV, and HDV. All right, so hepatitis C virus. This is a positive sense RNA virus with a flavivirus structure. It's spread parenterally, blood, needles, sexual contact, and perinatally. So very similar to HBV and HDV. Also, like HBV and HDV, we've got a prolonged incubation period and an insidious start to those icteric symptoms. It's even longer for HCV, anywhere from 14 to over 180 days between when the patient might have been exposed and when you might see symptoms. And it's so insidious that HCV is one of those ones that we're actually worrying more about baby boomers than we used to, because they may have been exposed to HCV so long ago and had kind of this asymptomatic carrier or chronic infectious status for years that we've just been unaware of, and now they're starting to present. It causes chronic hepatitis in many patients, up to 70% of patients, and it is associated with hepatocellular carcinoma. It's a widely prevalent virus, over 170 million chronically infected carriers of disease worldwide. So that's why this is kind of a major public health initiative, and you might be seeing commercials for it on TV because we now have some more effective treatments for it than we used to. Okay, it's a flavivirus. There are 6 major genotypes or clades. Between or within each genotype, there's actually considerable genetic and antigenic diversity. It has a positive sense RNA genome, and it is an enveloped virus. Now, the other thing to keep in mind are these various enzymes. It has 2 glycoproteins, E1 and E2, but the rest are all non-structural proteins. But these NS proteins, don't let them fool you that just because they're not structural, they're not important. They're actually really important for enzymatic activities. So NS3, 4A, 4B, and NS5B all have enzymatic activity. And many of the new anti-HCV drugs actually work against these. And they're named based on the non-structural protein that they work on. So you can use that to kind of determine how your treatment is working and what your drug target is. And that can be really helpful for memorizing. Only humans and chimpanzees are able to be infected, and it binds to a lot of different cell surface receptors on hepatocytes and B cells, CD81, SRB1, Claudin-1, and occludin. Replication for HCV is really hard to figure out. It doesn't grow well in culture, so we're kind of going to skip over that for now. We're going to talk about the pathogenesis. The pathogenesis is immune mediated, and this is kind of what happens. So you have your hepatocyte, it gets infected, it releases type 1 and type 3 interferons, which activate NK cells. It also leads to antigen-presenting cells picking up apoptotic cells or other cells that have been infected and presenting them to CD8s, CD4s, and providing crosstalk to NKs. So all of this is going to cause a lot of damage, right? Because the CD8s are going to produce interferon, TNF, perforin, granzymes. The NKs are going to try to kill by similar mechanisms, as well as ADCC, once we engage the B cells, which will be engaged by the CD4 T helper cells. So this is kind of the acute response that's going to lead to liver damage. But then remember, 70% of patients go on to become chronic. So what happens? Eventually, we kind of get some engagement of Tregs, or the response goes on so long that the CD8 T cells become exhausted. Either way, we're going to get upregulation of CTLA4, PD1, kind of skewing to different classes that aren't as effective. So then we have this chronic infection. And that's going to be a problem because we need the immune response to resolve the infection. So if we move to chronic and we start exhausting our T cells, we're not going to actually clear the infection. The antibody is produced, but it's not really protective. So even though we can use it as a diagnostic marker, it's not doing much for us. So chronic hepatitis is going to be what happens in about 70% of patients. Diagnosis is made by anti-HCV antibody, or, and this is kind of gold standard, detection of the RNA genome, because that's going to tell you how much you have and if your treatment is working. And the antibody can be problematic because seroconversion takes 7 to 30 weeks after infection. And it's not always detectable in viremic people, immunocompromised patients, or those receiving hemodialysis. And immunocompromised patients are actually a bit of a problem because HIV and HCV co-infection is actually fairly common. So in these patients, we might not see the antibody, doesn't mean it's not there. So that's why we're going to look for the genome whenever we possibly can. You can have acute or chronic hepatitis that moves on to the icteric phase, where it can cause cirrhosis or the associated hepatocellular carcinoma. All right, so our patient for this was Kathy Everdeen. She's an insurance claims adjuster who is seeing her primary care for a routine physical. She's had asthma for a while. She's from Naperville. She's never really traveled abroad, but her ex-husband served in the Vietnam War. She doesn't smoke, drink, or use drugs, hasn't been sexually active in years. Her doctor has noticed on several occasions that her platelets are slightly low. So they do some blood work and they find that she's HB core antigen positive. Now, that basically means that at some point she resolved an HBV infection. She's HB surface antibody positive. So again, resolved infection. If she only had HB surface antibody and no core antigen, I would say immunized. She has HCV antibody positive and she has a high RNA titer. And notice we're also listing the genotype here. That's because for treatment, there are various treatments that only work on specific genotypes, are not pan-genotypic. So you're going to want to keep that in mind when you're making your treatment decisions. So she's negative for HAV. So at some point, we might want to consider vaccinating her for that, right? HBV, she's already resolved it, so she's immune. HCV, she's getting cirrhosis. She's had it for so long, probably since her husband came back from the Vietnam War. So now she's got severe liver damage happening. But we can treat it. So we can give some of our HCV treatments. You're going to give them for about 12 weeks, and then you're going to recheck, okay? All right, the other patient we had was Mikey Eakins, and he was kind of the star of the show with this one. He's a 49-year-old male with well-controlled HIV. His most recent CD4 count was 355, and viral load was undetectable. He is sexually active. He has a boyfriend of 2 years who's also HIV positive, but they use condoms. He's from Southern Indiana. He moved to Chicago 6 months ago. He's a project manager. He doesn't smoke. He takes his antiretroviral routine, abacavir, dolutegravir, and lamivudine, and he struggles with migraines as well. So if we look at his labs, he's been vaccinated for HAV, he's been vaccinated for HBV, but he has HCV. So either he picked this up years ago, maybe when he was infected with HIV. So we look at his results. He's immune to HAV, he's immune to HBV, he's chronically infected with HCV, and nothing going for D and E. Now, if he had contracted HCV in the last week or the last month, if it was the last week, we might not see HCV antibodies, but we would see HCV RNA. Remember, he is immunocompromised, but his CD4 count is pretty good. If his CD4 count had plummeted, though, we might not see the antibodies. The titer could eventually be affected if it was an acute HCV infection. If it was a chronic HCV infection, we'd probably still see titer. All right, and that's all I have on HCV.